Good afternoon, everyone. Welcome to the Tobacco Settlement Agreement Fund Oversight Committee meeting today. Hope everyone is having a blessed day and obviously safe travels in for this afternoon's meeting. Rachel, start us off. Please call the roll.
Senator Chambers Armstrong, Senator Herron, Senator Reed, Senator Richardson, here. Senator Webb, Representative Pfister,
here.
Representative Hancock, Representative King,
Present.
Representative McPherson,
Here.
Representative Works,
Here.
Representative Dossett, Co-Chair Howell, and Co-Chair Pollock.
Here.
We have a quorum.
So we do have a quorum. We need to approve our minutes from the last meeting. We've got a motion and a second. All in favor, please say aye. And those minutes have been approved. Just a couple of housekeeping FYIs. Committee, don't forget about tonight's reception. They're in Versailles. It starts at 6:30 at the Amston Station. So hope everybody in the committee and in the Agriculture Committee as well is invited to come to that. So just kind of remind you all of that. Senator Co-Chair Howe, any words of wisdom from you before we get started?
No, Chairman. Thanks for chairing today. My voice is under the weather a little bit. I know there'll be a lot of people happy about that. But I just look forward to this. I think this will be a real productive meeting. I want to thank the Cabinet for all the information, and it's nice when we can work together to help people in the Commonwealth rather than play political games, and I'm looking forward to getting into this.
Good deal. And yes, I thought this whole process here is, again, we're being the Oversight Committee for the Tobacco Settlement Fund. Is a process that we did last Monday, and now this Monday we're finishing up with everybody and what we're going. So first up this afternoon is a Behavioral Health, Development, and Intellectual Disabilities group. Would you all please come to the table, introduce yourselves?
Good afternoon. Sarah Johnson, Director for the Division of Substance Use Disorder within the Department for Behavioral Health, Developmental, and Intellectual Disabilities.
Good afternoon. I'm Rachel Dockel. I'm the Director of the Division of Administration and Financial Management at the Department.
Is your mic on, Rachel?
It is, but I can move it closer
Yeah, move that
to
a
me
little
if that
closer
helps.
to you both, if that's okay.
All right.
Well, thank you all. Thank you for being here this afternoon. You may begin.
Okay. So as we said, we are here representing the part of the tobacco settlement appropriation for the Department for Behavioral Health, Developmental, and Intellectual Disabilities. The department receives an annual appropriation of tobacco settlement funds that is targeted specifically for use for substance use prevention and treatment for pregnant women. Absolutely. I usually don't have to worry about being too quiet. You're welcome. So to give you some information about the current year budget and prior year expenditures for that, our programming initiatives around substance use prevention and treatment for pregnant women incorporate funding from the tobacco fund settlement that we receive annually, in addition to using prior year tobacco settlement carry forward dollars within the department appropriation. We also receive restricted funds that begin their life as tobacco funds received by the Justice and Public Safety Cabinet, and those funds are targeted specifically to neonatal abstinence syndrome programming. We also use a small bit of general fund from our appropriation and some federal grant funds from the Substance Use Disorder Block Grant. So current year budget is about $8.7 million. And you can see the makeup of that, and state fiscal year 25 expenses right at $6.9 million. You can see in looking at those, the combination of the tobacco fund that we receive directly and the restricted fund that starts its life as tobacco fund with the Justice and Public Safety Cabinet is actually the bulk of all funding that is used for these programming initiatives. Of the 25 expenses, If you break down those expenses between administrative and program costs, you will see that our administrative costs are very small. We put about 3% of the total program cost into admin, majority in personnel for staffing costs. The remainder, about 97% of the program cost, goes out to direct services through partner contracts across the state. And if you look further down into those partner contracts, you'll see that we work with the community mental health centers, CMHCs, not-for-profit entities, other community partners that have a geographical spread across the Commonwealth and also have the proven track record and all of the things in place to be able to deliver these services Commonwealth-wide. This is just a listing of those partners and how much specifically in tobacco settlement dollars were put into contracts, paid out into contracts with them in state fiscal year 25.
So to go into a little bit about the programs that we support family and early childhood supports, prevention and early identification, treatment and recovery services, and workforce and community infrastructure. And again, this is for pregnant parents and their children, so those are where those services are targeted. How we select our partners, first of all, this is a specialized service. So we do select proven partners that have expertise in perinatal substance use, prevention, and treatment. We obviously work with partners that have demonstrated outcomes and use evidence-based practices, that have capacity to serve these high-risk populations, that have a strong compliance and performance history, and we partner with all of our community mental health centers. They are our statewide safety net and are mandated to provide coverage for all Kentuckians across the state. When we partner with these entities, we also provide accountability and oversight. We have regular performance and fiscal monitoring that we do with each of our partners. We also have ongoing technical assistance. All of our partners are in good standing, and this structure ensures the quality, service, and responsible use of public funds. The outcomes of these studies are really public health outcomes. The outcomes of these services are really public health outcomes that a lot of times take decades to really realize the full savings on this investment. But what you can see is from these types of services, there is projected up to $46,000 of estimated lifetime savings for treated mother and infant pair. We know that these services help reduce NICU stays and maternal complications for pregnant women. It lowers child welfare and criminal justice involvement. The treatment benefit to cost ratio is 10-1. Prevention strategies yield even higher long-term savings, and this reduces increases system-level benefits by reducing Medicaid expenditures, improving overall maternal and infant health, and improving the stronger family stability and workforce participation.
And at this point, this wraps up the information that we have provided for behavioral health. If you have any questions directly for us, we'd be happy to address those. If not, we will tag out and let the next group come to the table.
Well, thank you so much for your presentation. I did mention before we even got started, and just obviously the committee was here last Monday, and you guys, for the first, people here in the room, wanted to kind of share with you in detail what this whole thing's about. Obviously, during the interim, the programs come and tells us what you're doing and those type of things. Today, we're targeting in on specific how the money that you're getting, how you're using it, and the results. And so basically, I want to read this to you, and then and then we'll get into it. And so the Tobacco Settlement Agreement Fund Oversight Committee is required to review expenditures under the Tobacco Settlement Agreement Fund. As part of the biennial budget process, committee members will be evaluating each line item recipient of the Tobacco Settlement Agreement Fund to analyze the total return on investment of those funds. Committee members have a responsibility to ensure that each dollar received under these programs is used for maximum benefit for the Commonwealth. This responsibility becomes even more important as the funds continue to diminish as society continues to move away from the tobacco use. So that's our intent of why we're here today. The people that are presenting today got 3 questions pretty much that we were kind of consistently looking for in an email. These people presenting today did a really good job of providing that to us. Obviously, we're going to probably have a few questions, but everybody in the room, I want to applaud you for your efforts on bringing us the information that we asked for in these 3 questions. I'm not going to get into the weeds of what those 3 questions are. You know what they are because we got the information for the most part, what we were looking for. So I want to say thank you. So we do have a question, and thank you for the presentation. I think Representative King, you're up first.
Thank you, Mr. Chair. I have a brief comment and then one question. Nomenclature, wording, and definitions are really important to me in my work here. So just to be clear, a pregnant parent has to be a pregnant woman. So that's important to me. If we could go to page 9 in our packet where each of the 4 services are listed there, to the chair's point of how much return on investment the taxpayers are getting, do you have a census on how many women are served in each of those 4: prevention and early detection, treatment and recovery, workforce and community infrastructure, and family and early childhood supports?
So we put these in broad buckets today because at the program report out, we provided those numbers. I would be happy to provide that back to you, but I did not bring those numbers back today.
Okay, that might be really helpful for us to
Absolutely.
complete this work. Thank you, Chair.
Yeah, and for the record, if you guys don't have specific information, I know you'll look it up and get it to us, and that's perfectly fine, okay?
Absolutely.
Senator Howe.
Thank you, Mr. Chair, and thank you for your presentation today. Again, I'm not trying to catch you up on anything. We can trail whatever. But one of the slides talked about identifying high-risk populations. How do you go about doing that? How do you identify high-risk populations?
Right. So for these funds, of course, this is for pregnant women who are at risk or are already using substances. So with the prevention, obviously, we try to prevent that use from occurring, but then we also try to prevent the negative consequences if the use has been initiated. So we do that through various ways. We obviously work with community treatment partners across the state, and so part of that is screening and asking those questions when someone is receiving services out in the community. We also know that there are areas where there are less services provided, and we want to make sure that we are providing services in all of those areas to reach anyone in need of services.
Thank you. So it sounds to me like some people will be pre-identified because they'll be in a treatment program or in something. And is there ever any instance on the flip side where somebody goes to neonatal and blood tests show different things? At that point, can the medical providers engage you then?
Absolutely.
Can you talk to me just briefly through how that part works?
Absolutely. Yeah, so we work with across the entire continuum. So from prevention to treatment all the way through. We have partners with places like St. Elizabeth that obviously is a medical center that can provide or can identify women that have substances, whether they're pregnant or they've given birth, to be able to make referrals within their own network and with the other programs that we support. We also work with partners across the state to be able to make those referrals from that hospital to that treatment facility.
Is there anything that you run into during this process that inhibits the flow of information back to you on people that are identified in the neonatal world as being at risk that we need to have more wraparound support services for? Is there anything from a legislative standpoint that you think we could address there?
That's a great question. I really appreciate you asking that. I would love to take that back and consider it.
I'm a lot better at questions than I am sometimes.
Well, when you ask us for our wish list, I want to make sure I'm giving you the correct wish.
Well, I just like the proactive nature of this. I think all of us get frustrated at
Absolutely.
something. We always feel like we're reacting, and to be able to get in on the front line on something like that is so important, not just for the women that we're trying to supply services to, but for the lifetime of the children they're getting ready to have too.
Yeah.
So I was just, a lot of times there's things that just get in the way intentionally or unintentionally, and I just wondered if you'd ever come across anything like that.
I'm sure we have. Collaboration can always be improved, but I would like to take that back and talk with my team that does this work day in and day out, because they could probably speak a lot better to that than I can.
Yeah, thank you.
Thank you
Mr.
so
Chair.
much, though, for that offer.
Representative McPherson.
Yes, right here. So,
Yeah.
so I understand y'all are the early childhood mental health. Is that correct? So you're talking about women and children. What's the age? Is it from K through fifth grade? Where you at with this? What ages and who's eligible for this? And is anybody just eligible, or do you have to fit certain criteria?
So there's different programs that have different eligibility. Within the department, we have the early childhood consultants that work with young children that are either have been exposed or are at risk to be exposed with substance use. We also have funding that comes through public health to our department for the early childhood mental health consultants that we also provide the mental health services on. I don't have the exact age range, but it is the younger age, because they were trying to identify and intervene very early to improve the trajectory of that child's life.
So, if I may chair this one.
Yes.
So once you identify these and they say they're K through 5 and they go through the program and maybe you see that you're making progress with them, but what happens when they age out of this? Is there a way to follow them, or how do we go about this?
Absolutely. So while these programs are designed for younger children and pregnant women, there are programs that we support throughout the entire continuum to reach all Kentuckians that are in need. So even if they age out of a particular program, there's a warm handoff to the next program to be able to provide any continued services that they may need.
Okay. Thank you, Chair.
Thank you so much. Anything else from the presenters at this time? Appreciate you getting this information back to us that
Absolutely.
we've asked for. And thank you so much for being here today.
Thanks for having us.
So, community So next up, we have the community-based services. Good deal. Please introduce yourselves, and you may begin.
Hi, I'm Misty Sammons. I'm the Director for the Division of Administration and Financial Management for DCBS.
And my name is Andrea Day. I'm the Director for the Division of Child Care within DCBS.
Thank you for being here this afternoon. And your presentation may begin.
Okay. So we receive funding for tobacco funds for child care, early child education, and then also for foster care supports. So the child care funding we receive in 2025, we received $9.8 million of tobacco funds. This year we were appropriated $9.5 million in tobacco funds. The funding for child care is a combination of tobacco, general, restricted, and federal funds. The federal funds is the biggest portion of funding received for child care. You can see in 2024 there was a large amount of federal funds, and that was due to the COVID pandemic dollars that we received. The general fund appropriation did increase from 24 to 25, and that was due to appropriations that we were awarded in the budget to continue some of the initiatives that we started with the ARPA funds that we received. These are the programs that the tobacco dollars support with child care. So we have the All Stars program, which is the quality rating and improvement system for early childhood education programs. So when a
So the All Stars program is a voluntary quality rating and improvement system that we have had in place for some time now. Our providers are rated levels 1 through 5, with levels 3 through 5 being considered high quality. And so these funds pay their award incentives.
Okay, so basically 68% of the tobacco funds go to that program. 12% is for quality initiatives or quality incentives, and that's where we pay extra funds to providers if they have special needs children within their facilities, or they offer non-traditional hours in their facilities. 8.3% was for non-college scholarships. Those scholarships help support the workers in the programs or for the providers so that they can continue their education. 560,000 was used for child care payments. That's for people who couldn't afford their payments. We subsidized some of those costs. The professional development registry is a registry that we have because individuals working in the regulated child care must maintain a record of their training. So this registry documents the completion of statutory required annual training hours. And then there was various admin costs in there that was less than 1%. And the biggest part of that was for the environmental rating scale software that's used for the All-Star surveyors. This is just a quick glance to show you the All-Star levels by provider type. There were 25 programs that opted out of Kentucky All-Stars in 2025. And then we received $2 million in tobacco funds for protection and permanency, which is kids in out-of-home care. That funding, the funding for protection and permanency is also a combination of tobacco, general, restricted, and federal funds. The majority of it being general funds. You can see how expenditures continue to go up for this program. So 81% of the funding that we received is used for foster care supports. This funds per diems for foster parents, relative and fictive kin caregivers. Those funds are used to assist with housing, food, clothing, school supplies, all the things kids need. And then about 19% of the funding go to the children's advocacy centers. We'll take questions if you have any.
Can you kind of share a little bit more? You mentioned scholarships. Mm-hmm. And one of the questions we're talking about investment, basically of the funds that you're getting and the scholarships. Share a little bit more detail. I didn't know for sure if there are a total amount of those scholarships, and those amounts going to the scholars of going through their program. How that's working out once they graduate. Are they staying here? Are they moving away? Just kind of talk a little bit more in detail of the scholarship.
So not to complicate things, but I might just a minute. There's actually two different sets of scholarship money because there's an early childhood development scholarship program that the Kentucky Higher Ed Authority, there's an appropriation for them, and that is currently covering all costs related to associate's, bachelor's, and master's degrees for anyone working in regulated childcare to have their full tuition covered under that. We have seen positive results from that. I don't have those numbers with me. But the ones that we're talking about here also goes to those folks that maybe aren't on a college track, but are seeking that a credential. So we are incentivizing them. I don't have retention numbers. I'll be very transparent, and that's somewhere that we are working to be better at so that we can answer that question for the retention. But I will say with a number of other programs that we have instituted within child care, we are seeing folks staying in the field because of the opportunities that they have now.
Any idea of like a number of scholarships that you would use over, and you can give us that information, but I just thought maybe you could kind of give us an idea, but go ahead.
And these are in calendar years, so I apologize. We do a CDA mini grant, which is the Child Development Associate, which is a nationally recognized credential. In calendar year 24, we offered 318 of those. In calendar year 25, that was down to 218. Milestone Achievement Awards, it was 203 in calendar year 24 and 178 in calendar year 25. And then we also have a very small portion of related education reimbursement that we do, and those were less than 100 in each calendar year.
That's what I'm looking for on those numbers like that. Just one more quick question on my follow-up, in that obviously someone who gets that scholarship through tobacco settlement funds and they get that certification, do they typically kind of are they allowed to start their own childcare in our areas? Or
They could. They do have that opportunity. Anyone does. But there's no startup grants currently. But yes, as we see folks attain higher education, they think more business minded, like, how could I do this? And so we do have some that do open their own businesses or their own certified family child care home.
Thank you so much. Any questions? Representative King.
Thank you, Mr. Chair, and thank you all for your presentation. My question kind of comes from slide page 11 and report page 3. I'm kind of taking the information from both. Since the All-Star program is the vast majority, that 68%, that's what drew my attention. And then in the report, it talked about the providers or the workers completing their required training. So again, just trying to get to that return on investment. The chair read my mind on, are we getting benefit and long-lasting benefit of that? So I appreciate getting that follow-up. Thank you, Mr. Chair.
Representative McPherson.
Kind of on that same line, so I'm a real estate appraiser by trade. Are any of these non-college scholarships, are they certifications like through our trade schools, or what are those?
They are the Commonwealth Child Care Credential, the Kentucky Director's Credential are a couple of those.
Okay. All right. Are these people, are they contractually required to stay in our state once we help with these scholarships?
They are required to. There is a minimum amount of time that they have to stay. I'll get that back to you.
No, we're just looking on return on dollars. So if we're going to put the Kentucky dollars out, we'd like to see those people stay in our state. I know when I was, I'm going to tell my age, but when I was a long time ago, they had a scholarship out for math teachers, and my mother was a math teacher, and I considered being a math teacher, but you had to teach for 5 years to pay that scholarship back. I did a little teaching, helping out as an aide in a class when I was a senior, and I decided that probably wasn't for me. So thank you for your time.
Committee, any other questions? Senator Howe.
Thank you, Mr. Chair. Thank you all for your presentation today. I've got just a couple of follow-up questions for what Representative McPherson was saying. And I know that some of this, everybody has these great ideas, and it all trickles down to people that in your department have to go in and deal with them and everything. But I know that in our industry, we have a lot of turnover on this, and being able to track how many people stay in have we ever gotten to the point yet of trying to identify the whys on why we don't stay in? And maybe that could be something that we could work toward too, maybe in cooperation with us if we need to do some things.
Yes, anecdotally, I can tell you that a lot of folks leave this field because of low wages. I know several committees have heard folks testify that 98% of all other occupations make more than a child care provider does, despite how hard the work is. And then small businesses being able to provide competitive pay and salary or benefits is also a struggle. And so those are some things that we have been looking at. We have done a few surveys with folks, but that stays consistent with what we hear nationally as well.
Thank you, Mr. Chair. I believe that's all I have.
Thank you all so much for your presentation. Look forward to getting a little bit of that information back, and have a good day. Thank you. Looks like last up maybe is the public health.
Who's coming up? Good afternoon. I'm Julie Brooks. I'm the policy specialist with the Department for Public Health.
And I'm Mike Tuggle, budget officer for the Department for Public Health.
Andy Waters, Assistant Division Director for Maternal Child Health in the Department for Public Health.
Thank you all for being here this afternoon. You may begin your presentation.
Thank you. So we'll start with our largest program, which is the Health Access Nurturing and Development Services, or the HANDS program. And as you can see here, this program receives a mix of funding through the Tobacco Settlement Agreement, general fund dollars, restricted funds, and federal funds. The tobacco settlement dollars are used to support program implementation. None of that funding is retained at the state level for administrative cost. I know that was one of the big asks. We allocate funding to our local implementing agencies. Those are primarily our local health departments. The hand services was defined in 2020 as a core public health service. So it is a service provided through most of our local health departments. We also have some not-for-profit agencies that we contract with to implement the services at the local level. Allocations to the implementing agencies are based on the number of services that they provide and how their previous year's allocations were utilized. So if a local implementing agency has an increase in families that they're serving, their increase in services, we may do a mid-year adjustment to give them more money. Again, conversely, if there's a drop in population and a drop in services, funding may be reallocated from a lower performing local implementing agency. We monitor this continually throughout the year. The federal government, because we receive funding through them, they have performance benchmarks and performance measures that all states who receive federal funding have to meet. So the local implementing agency actually collects that data and reports it back to the state, and then we report that on to the federal government, and that's how they determine at the federal level how well we're performing as a state. Anything else? So the return on investment, we see this as being healthier children, healthier families. I shared in the report that in our last data reporting to the feds, we had 94% of women received postpartum care follow-up, which is a significant increase. 78% of children were receiving that well child visit. And what I think is most astounding is that 94% of children were having a parent or a family member that was reading to them daily. So we're getting helping families move toward that self-sufficiency, helping that early learning, helping that early childhood development.
Ma'am, can I just say, wow.
Thank you.
That is awesome. Mm-hmm. Please continue that good news.
Yeah. Well,
let's see you top that one.
Well, and this seems sort of the reason why we're here today to talk about how funding is being utilized is our smoking prevention and cessation program. They do receive tobacco settlement funding as well as federal funding. Again, the tobacco settlement funding goes toward program implementation. We use the federal funding for those administrative costs at the state level. We're all aware of the toll that smoking takes on one's health. And according to the Campaign for Tobacco-Free Kids, the average annual care cost in Kentucky directly related to smoking was $2.2 billion. And that was astounding to me. We obviously see we are moving toward decreased adult smoking rates. We're moving toward decreased youth initiation rates. The increased calls to the quit line. We know that for every dollar invested in a quit line, there's a $4 return on that investment. Our lung cancer screening is our newest program to receive tobacco settlement funding, and it is the only program that does utilize tobacco settlement funds for administrative cost. We had no other pot of money to support the staff, but we needed staff to be able to implement the program, so we used some of that money to cover those costs. It's approximately, about 165? Okay. $165,000 for staff cost out of the funding. And it supports our health program administrator and a part-time epidemiologist. The remaining funds support 7 programs across the state to engage in their local communities to address lung health and lung cancer screenings. The local events that were held reached approximately 23,000 individuals and 5,000 healthcare providers. We provide direct funding for uninsured and underinsured individuals to receive the lung cancer screenings. That funding goes to the healthcare facility that does that screening. We are also supporting 16 healthcare centers who are wanting to do quality improvement so that we can, make sure that we're getting the screenings, make sure that they're good quality screenings, because obviously the sooner someone can get screened, if they do end up with a diagnosis, they can get into treatment. So then you're reducing that long-term treatment cost. Our early childhood oral health program is another program that is supported with the tobacco settlement funds, and this funding is allocated to our local health departments for those those early childhood oral health dental care services, primarily the varnishes, which is, the protecting the tooth enamel. And the allocations are based off of the number of services that are provided. We support those at the local level. They can bill Medicaid for that service for those individuals that have Medicaid. But if they're seeing someone who's uninsured or has private insurance, that's not a service that can be billed to private insurance. So these funds are used to cover that service. We also have used funding to increase the number of our public health dental hygiene teams. We have one of the newest things is supporting dental school graduates in their loan repayment. And we are using that money. If they, again, like you were asking DCBS about the retention, it's a competitive process at U of L or UK Dental School. And if the individual is accepted, their application is accepted, they have to agree to work 4 years in an under-resourced area in the state so that we are getting that return on investment. The funding goes directly to the school to pay back the lender, so it's not going to the individual who then, does and go other things with it. So we are seeing starting to see that return on investment. The other thing is upgrading water systems. We have a number of smaller communities that don't have a lot of funding to support upgrades to that water infrastructure. So we've been able to really target those smaller communities. And when I say smaller, I mean less than 3,000 homes are on the water system. And so we're using this funding to help upgrade those systems. The Healthy Start program is one where the Department for Public Health receives the funding, but we then reallocate that to the Department for, this goes to DCBS. Yeah. So under the Public Health Transformation Framework that was initiated in 2020, this became an optional service for local health departments. It's designed to they work with the child care centers. They do a lot of training, a lot of consultation. They'll do the safety checks at those centers and do facility assessments to make sure that they are meeting those standards. But we do not retain any of this funding in the department. And then last is our early childhood mental health program. And Representative McPherson, these children in this program are age birth to 5. So these are not your K through 5 students. These are the younger students who may be referred from a healthcare provider, a child care center that need some early childhood mental health services. The state or the Department for Public Health receives the funding, and then we reallocate that to the Department for Behavioral Health, Developmental, and Intellectual Disabilities to support the early childhood mental health specialist in 14 of the community mental health centers across the state. And then we also do the early childhood consultants. I'm looking at Andy. Is that what? Child care health consultants. So some of this money is, goes to support the salaries. This program also is able to bill Medicaid and private insurance for those billable services, but there are a number of required non-billable services that they also pull from the tobacco settlement dollars for.
lot of information. Thank you so much. Committee, let me just kind of put everything in perspective here. Again, ladies and gentlemen in the room, in the tobacco settlement, there's 50% goes to agriculture, 25% goes to the early childhood development fund, and then another 25% goes to the healthcare improvement fund. Now, the information we've gotten today, other than the smoking cessation, everything we've heard today is actually in that early childhood development fund area, and so that's in particular what you're talking about here. So just wanted to kind of share those thoughts and making sure we've got that all in perspective of where we're at this point. So we've got a few questions. We'll start off with Representative McPherson.
So there's a lot of data here to drill down on. I really appreciate it. If I could just I'll try to take one at a time, but I talked about the smoking causing people to quit smoking. You said we're trending down. How about vaping? What are y'all do anything with vaping, or do you see that as the next problem coming up from this?
Yes, we have our local health departments that receive little mini grants. They're doing a lot toward youth prevention and getting out and helping educate on the dangers of vaping. They're also working with the school systems as an alternative to suspension if a child is caught with a vape, to kind of get that education, keep them in school, but also help educate them. We are seeing some reductions, but not as quickly as we would like.
Great. If I may.
Yes.
So you're talking about the dental hygienist and working with them. I really wanted to kind of drill down on the 16 water units. I'm a real estate appraiser by trade. I'm served on the housing task force. We're always talking about infrastructure, water systems. Everybody's always kind of coming to you saying, how can we expand? The state of Kentucky has water available, but a lot of times it's in real small lines, and as we're growing, we're trying to expand our system. So can you identify these 16 water units or water systems that have been done, and kind of a little bit of detail on what y'all did with those?
I'll have to get back with you on that. I'll get with our oral health team to get that exact information for you.
Okay. Thank you so much. Mm-hmm. Thank you, Chair.
Yes. Couple questions I've just kind of thought on the smoking cessation. Is there a target kind of age group when you're talking about just kind of proactive situation, or is it just all in one? Talk a little bit about that.
Prevention is primarily targeted toward youth, so that if they never start, then they don't have to stop.
Absolutely.
The cessation really is, anyone at any point in their lifetime, and helping them stop.
You apparently, is there a hotline that some people that may be able to call and just trying to get some help? Obviously, when and so is that hotline used by, I guess, smokers or any doctors or any other? What's that? Can you share a little bit more about that?
The quit line is primarily for the individual who is wanting to stop smoking.
Gotcha.
It may be that the physician refers them to contact the quit line, so they can receive. I'll have to hold just a minute, Elizabeth. How many services do they get?
They get 5 phone calls and anywhere from 2 to 6 weeks of nicotine replacement therapy.
Gotcha. And
5 phone calls and anywhere from 2 to 6 weeks of nicotine replacement therapy is available.
And the reason I ask that, obviously, the hotline's not for a doctor, but my point is it's a sense of resource that everybody involved helping this particular person can go to and that sort of thing. Do you keep up with how many people have quit smoking through your program?
We do, and that was included in the report.
Okay, good deal. I just double checking on that. Any other questions? Representative King.
Thank you. I'm rather chatty today, aren't I, Chair? Talking about the oral health, what got my attention is at the bottom of page 6 of the report, talking about the upgraded water systems, talking about public and municipal water systems is a recurring theme here in the General Assembly. So I'm just wondering, what type of upgrade is there if it is or isn't fluoride related? What other types of upgrades promote good oral health?
It may be improving the water lines, some of the older lines that may have just degraded over time. So that equipment might need to be upgraded. It could be the pumping equipment to get the water out to the homes. Those would be the types of infrastructure things outside of anything related to fluoride.
May I follow up?
Yes, please.
Okay, that's all wonderful and good. As Representative McPherson said, we really need to get all of our infrastructure updated, but those infrastructure upgrades seem to be that would just help us have good water in our homes and businesses. I'm just wondering how that directly improves early childhood oral health.
That's a really great question. We know that, one of the things that will help a child is having good water in their home, that hydration, helping them, when you think about, particularly, I think like older lines that may have lead in the water and the child's brushing their teeth, that could kind of help or could erode the enamel over time. So improving the water will help improve that oral health over time. So that reduces the cost needed for the dental care.
So I guess my point is, if we're investing in that, the entire population of 3,000 people using that water line improvement are going to benefit as well. Yeah. I mean, I'm not saying it's a bad thing. I was just trying to figure out how it directly affected oral health for little kids. Thank you.
You're welcome.
Just follow up, Representative King, with what you were sharing. You mentioned application in your presentation on the oral health. Mm-hmm. Now, when I was a young boy and I had to put that fluoride treatment, that mouthpiece in, and it was just... Is that the application you're talking about, or is there something new application?
This is a new application. This is actually, it looks like a toothbrush where they're painting the varnish on the teeth that kind of helps then strengthen that enamel.
Good deal. One other question, and then I think I got Senator Howe to ask, but you brought 4 or 5 different topics to the table, so I'm going to go back to lung screening.
Okay.
You mentioned the different facilities and all, and I think you mentioned the number 23,000. Mm-hmm. Are those screenings of people?
No, that was the number of individuals that we reached to kind of start that education process.
Okay, so that's the education part. Mm-hmm. Is there a number of who actually... So where I'm going with, we had and it's still just it made a really emphasis on me during the interim where the screening, University of Louisville, University of Kentucky came in and presented. Actually, let me find my paperwork here. It's the cancer research screening. It's actually in the healthcare, and they shared with us the money and the investment, and they talked about actual screenings that was being done across the state through mobile units. Mm-hmm. And those type of things. And so I was just curious if this process that you all were doing was similar to the one they were using, and what results you may have in actually people having those type of screening to catch it early. Is that something is this what we're talking about?
Yes.
Can you talk a little bit more in those details or the process?
I'm not as familiar with the process, but if you will indulge me, I can get you more information and give you greater information on how the process actually works.
Yeah, I just the actual numbers of people actually being, whether it's at the state fair, wherever that part of it is. Obviously, the information and starting the process is super important. But again, that information was given us to them in their interim, and that was really intriguing to me. And wow, if we can find and help people get it before it gets down the road, obviously that's a huge impact on our state. Senator Howe.
Thank you, Chair Pollock, and thanks for the visual or the reminders of those fluoride trays. If I have flashbacks in the middle of my questioning, I apologize for it. That brought back memories. We'll just leave them as that. We won't grade the memories. I'll follow up just on a couple of things. Representative McPherson was talking about some of the follow-up information for oral health. Those water systems, how do you identify those? Is there any criteria that was in place for identifying which systems were chosen for the support?
It was a competitive application process. Our staff in the oral health program really kind of initiated that because they work on a regular basis with these smaller water systems, and they were able to, get with them, get the application process started, and go through a competitive process with that.
It didn't have anything to do with your more high-level tobacco areas. This was just an overall oral health thing.
Yeah.
Okay. Going back to the dental school loan repayment, a couple of questions on that. I like the concept of that. I think that's some things that we're going to broaden out and probably already are doing and look to doing some more in some of our underserved areas with different things. How do you match the dentist to a particular area of need? Is there anything that you look at in that regard?
Again, not being the program staff, I'm not sure.
Can you just trail that information? I don't want to put you on the spot. I don't see how you keep up with all the things you do. I'm not trying to put you on the spot on this, but I was just curious to see how we identified that. I know some of the things we've talked about in other space. If there are certain people that are from a certain area, they're more likely to go back to the area. So maybe they would have a better chance of staying with it for the long haul, and that might be the most effective use of our money. I'd be curious to see how y'all's criteria breaks down on that.
Okay.
If you don't mind trailing that. And then I think this was kind of touched on, and if I'm repeating something unnecessarily, I apologize. But how will people, once they have to stay 4 years, I believe you said, to be able to get the loan repayment help. If they stay the full 4 years there, whether they stay the full 4 years there, and if they do we trail them and see how long they stay after the 4 years? That's some things that I think could be helpful as well.
Okay.
It's difficult in some areas. If I'd have wanted to take my wife all the way home when we moved home, I might have had some unpleasant outcomes. So there's a lot of factors that go into play in people's lives. I was just curious to see how that sort of thing trailed. Going in, I want to talk a little bit about lung cancer screenings and smoking cessation groups, and I'm going to ask this question together, and if we need to break it out, we can, but it seems to kind of conceptually fit. We talk about you said in some of the stuff there were like 8 healthcare facilities that are receiving funds, and I believe there was 4 healthcare facilities that were doing additional messaging on smoking cessation. How do we identify those areas? How do we decide where to put these facilities and target these facilities?
It's a competitive application process for our local health departments, that if they've identified that as a local need through their local needs assessment, they can apply for the funding to do the prevention, cessation, those types of activities. And then the others, I know UK, we partner with them because they have a program that targets youth. And so that's one of the other partners with the smoking cessation program.
I just thought of another question. Hang on. That'll teach you to give a good answer to a question, won't it? No good deed goes unpunished, right? Just generally, I'm not trying to be funny by saying hotspots in reference to smoking, but is our data granular enough where we can see certain areas of the state where smoking is probably in a higher density than other areas? How do we do that, or do we do that?
That's an excellent question.
See, I told you I'm better at questions than answers.
And so am I. That is one I would have to ask our smoking and tobacco prevention and smoking cessation program staff.
Yeah, if you don't mind trailing with how that works. I know I pointed this out to my kids one time. We were in grocery store in a different part of the state from where I live, and the cigarette counter was actually in the grocery store was actually a manned separate counter, and in other parts of the state I haven't seen that. So I'm sure that there's metrics and ways to track this sort of thing, but I think it'd be informative to us to know how that works, because then we can look at some of the things that we've been doing and targeting those areas and see what works and what doesn't. Maybe we need to go in a different direction here or apply something that's worked somewhere else. I know that y'all probably look at some of that stuff too. I'd be interested also to hear how you guys evaluate your own data to see what's working and what's not, and to be able to kind of address those. You know, everybody, I'm guilty of this too. I'll have a great idea that I think is going to work, and I apply it, and it doesn't work that way, or maybe it works one time and not to somebody else. So I'd be curious to see how y'all evaluate how your performance metrics are on stuff like that. See if you could provide that as well. So that was my question for both. I'm guessing your answer's the same for the. You know what happens when you assume, but I figured that was pretty safe. Can you talk a little bit about the Quills Quality Improvement Program and what that all entails?
Well, it's what little I know about it is that it is looking at healthcare facilities to help with their data monitoring, and they're promoting that best practices in those lung cancer screenings.
With these lung cancer screenings and smoking cessation programs, any of the stuff that you do, do you combine efforts in data sharing and everything with some of our other health issues like the diabetes or cholesterol, the heart problems? Is that all interrelated with how you work within the cabinet? Do y'all work together? Are there back-end teams that deal with all this stuff?
Yes, as a matter of fact, the part-time epidemiologist that works with the lung cancer screening program also works with the tobacco cessation program. So, she is looking at the data for both of the programs. And as far as the other chronic disease programs that we support through the department, they're all within the same division. So they're all right there together and can work in concert together.
That makes sense. Well, last question, I believe. On the Quit Now and all of your cessation efforts, do you track that geographically?
Yes.
So can you provide some of how that works? I'm curious to see where our efforts are based and everything, and what's working in certain areas that may not be working in others. I'm assuming, and if this isn't correct, please correct me, but I'm assuming we take the same approach everywhere. And what messages in one area may not message as effectively in the other. It's kind of where I was going with that. Okay. And I lied. I had one more question on the screen. You chaired. So with the screen,
your voice was sore.
I kept waiting for him to say that. I'm glad somebody did. You're my new favorite person to come. You're gonna have to come every time now. All the screenings, is there an age limit on that? Do we do that? Do we wait to a certain age to screen? Do we screen across age groups?
For the
lung cancer.
Oh, the lung cancer.
Let's start with there.
I'm not 100% sure. Let me.
Is it?
Yeah, it's supposed to, I think it's 50 to 80. 50 to 80.
Okay.
Is the age range.
I believe that's all my questions. Thanks so much.
Thank you.
Gentlemen, you can start your presentation. Any words of wisdom?
Thank you for
to
having
the committee.
us.
Thank you all so much for your presentation and the information. Committee, this basically concludes last Monday and this Monday, going line for line, and obviously and that is to analyze the total return of investment that these line items are getting throughout the tobacco settlement fund. So we're obviously in a budget session, and that is the whole reason why we had you here today, everyone. And so thank you so much for today and your presentation, and we'll get to work on the information. And if you can give us that information that we asked for, that will help us a lot.
All right, thank you.
Anything else? Are we good?